So the first disease state we're going to look at is celiac disease and how to treat it. And so the first and foremost method of treating celiac disease is quite simple but difficult to achieve, and that is to not eat gluten. And so that means avoiding, excuse me, wheat, barley, rye, bread, and beer, all things that are basically tasty and part of the Western diet. So the second thing to do is to manage diarrhea, which can be accomplished using some of the anti-diarrheal agents that we have talked about in the previous lecture. And of course, if that doesn't work, we can try prescription drugs. And that, at this point, we're kind of looking at what's deemed refractory celiac disease, or RCD. And that can be further differentiated by two types. Type 1 basically has a normal T cell ratio, so looking at the CD3 to CD4 T cell ratio, and that offers a relatively good prognosis. Type 2, I would say, is basically an inflammatory exacerbated celiac disease. And that's indicated by an aberrant CD3 to CD4 ratio or levels, and that offers a worse prognosis. And that's the one that really needs to be dealt with in terms of a lot of these more anti-immunity type drugs that we're going to talk about in this lecture. So the first group of drugs that are actually quite good at inhibiting the immune system are our old friends, the steroids. And so these are going to reduce production of many of the pro-inflammatory chemokines and cytokines at the genomic level, of course, that really kind of drive disease progression. And this concept cannot be stressed enough, that the immune system can actually, when it's misbehaving, can actually kind of drive disease pathogenesis. And so this is why these drugs are so important. They're part of what's called the induction therapy, and so literally it's the induction of a anti-immune response or an immune suppression type response from the drugs. Because remember, it's the immunity that's really driving this disease. There's three steroids that are listed there. They're in like a purplish blue color. Hopefully nobody's colorblind. But hydrocortisone, prednisone, and methylprednisone are our old friends. Hydrocortisone, of course, can be administered via a rectal suppository. Both prednisone and methylprednisone are orally administered tablets. But the new kid on the block is budesonide, which is kind of this newer steroid type molecule, which we'll examine right now. Budesonide mechanistically is going to bind to that glucocorticoid receptor, just like the other steroids that we just talked about, hydrocortisone, methylprednisone, etc. But it also targets the sodium potassium 2-chloride transporter. Is that clinically significant? You'll find out much later. We don't really get into the physiology of that particular transporter at this moment. But it can bind to that, which is why you see something like budesonide used in other disease states. Typically, this drug is administered for 8 to 16 weeks, and then the drug is kind of tapered off, and it has major effects on the bowel. And that's due to a couple of different things in terms of the physical attributes of this drug, but also the chemical attributes. And so the first off, this is enteric coated. And so basically this has a shell of chemicals around the drug that basically makes it more stable in the GI system so that the stomach acid doesn't degrade it as quickly. Okay, so kind of along that same lines is that this drug has a high first pass metabolism, which we're going to define in a minute. And because of that high first pass metabolism and the enteric coating, this drug has kind of local but direct effects on the GI system, particularly the intestines. And the systemic effects are greatly diminished because of these physical and these chemical differences about this particular drug. And so clinically, what's this drug used for? Crohn's disease, orally administered. PO is Latin for per os or by mouth. And then also, this drug has been used successfully in COPD and asthma if it's inhaled. And I don't think we talked about budesonide specifically, but it is one of those inhaled corticosteroids that's been shown to be quite effective in COPD. So here's kind of a key pharm concept that we need to kind of discuss, is this notion of the first pass effect or the first pass metabolism. And so generally, we're talking about a drug that is orally administered, and then because of the blood flow, we're looking at drug distribution from the GI system, then the liver. and you see major metabolic effects within the liver. So what does this mean? So here's a 50 milligram tablet that the patient swallows, and we know that if we were to assay the blood after some time, we're not going to see 50 milligrams of this drug in the blood completely. Okay, we'll see a slight reduction of it. So this is kind of standard for most of the drugs that we take orally, right? And so this loss of drug, this 3 milligram loss of drug, is due to metabolism, okay? And so, 3 milligrams of this drug gets converted into something else that either gets excreted, gets changed into another metabolite that doesn't have biological activity, gets converted to another metabolite that has extreme biological activity, and it can be a poison or a toxin, or could be just biotransformed and eliminated as a byproduct. Okay, so this loss of compound in terms of molecular volume is deemed the kind of the first pass effect. And for most drugs, we're looking at a relatively small reduction of the administered dose reaching the systemic circulation. And this, again, it gets to the biotransformation component. Now, with budesonide, we said this has a large first pass metabolism. So what does that mean? Well, so this is the opposite. So here, budesonide, 50 milligrams, say, are administered, 50 milligrams hit the liver, and 47 of those milligrams stay within the GI compartment. And only 3 milligrams of those administered of that administered drug can actually be observed in the serum. So this is great. So this means a maximal effect at the site of activity, or the molecular site where you want the drug to have its clinical effect, and a very low amount of drug systemically, because we don't want budesonide floating around in the blood. We don't want it touching the heart or the brain or the lungs. The goal of budesonide is really just to keep it in this compartment here so that it can reduce inflammation. And this is kind of illustrating really nicely, I think, the first pass effect. So here, this is most drugs having a relatively minor first pass effect. And here's budesonide, which is unique that it has a large first pass effect. Okay. Other drugs that have large first pass effects include statins. Okay, so it's no miracle that statins work so well, because a large percentage of the actual dose you give the patient gets biotransformed at the site of the molecular target. It all happens at the liver. So the drug gets activated here, and the HMG receptors that are supposed to bind to the drug are already in the vicinity of the organ that activated it. I mean, you can't ask for anything better than that. That's perfect planning in terms of nature. Okay, so that's kind of a quick foray into the first pass metabolism. And that's kind of the a good introduction to steroids in the use of some of these inflammatory GI conditions.